All right, ladies and gentlemen, we're very, very honored to have Dr. Gorav Ailawadi here as faculty for this year's Re-Evolution Summit. Welcome, Dr. Ailawadi.
Thank you so much for having me, Ziyab.
It's a pleasure of ours to have you here. So you've made quite a name for yourself in the field of minimally invasive cardiac surgery. How is that journey like, transitioning from general surgery to cardiac surgery to going towards minimally invasive? Like, how is that transition for you?
Let me take a step back and say, I think every step along the way you learn things, and you have to learn everything you can. So even general surgical techniques will translate to some degree to cardiac surgery. Open cardiac surgery obviously translates, but each move that you make, there's new skills, and coming to conferences like this, talking to other experts, going to watch, you can really adopt things more quickly. I think there's a lot more now with simulations, so you can adopt those and practice those things. We heard about a lot of those things this morning, some of those new simulators, which I think will make learning curves for younger surgeons a lot quicker than it was for me.
Yeah, I've noticed that because at your time, when I think about it, there was no formal minimally invasive training program. And I feel so lucky to be in a minimally invasive program, which I learned from Dr. Ramchandani's experience. And he basically has created a curriculum for me to advance. And I feel like he had to learn it all by himself. And it took him years and years of trial and error. Yeah. Was that something like that for you as well?
So it's interesting. I had an interest in minimally invasive surgery even as a general surgery resident. You know, laparoscopy had become fairly standard for lap choles, but it was now starting to span into adrenalectomies, nephrectomies, a little more advanced things. And I was kind of a mid to senior level resident during that time, and I got very interested and excited, and some of the faculty I work with really saw that I was interested. In fact, one of them in my going away book said, you should make sure you use a scope and a camera. You know, this is something that you enjoy and you're good at, and you're gonna maybe make an impact. So it took a while, of course, to translate to cardiac surgery. We lagged behind. The technology wasn't there. But when I first started doing minimally invasive cases, you went out to like a weekend course sponsored by a company. You watched a surgeon do a few cases very slickly, and then you try to do it, and you failed.
Absolutely.
And you failed.
Yeah.
So my first several cases were very hard, not the best outcomes. And my mentor said, time out. This is not, you shouldn't be doing this. Okay. So that was within my first couple of years of training, and I think there's better models now, experience. Maybe you should first learn to be a mitral surgeon before you start using minimally invasive techniques. You first know how to really manage the pump, how to protect the heart as well as you can. So those things come with experience even before. That's what I said before. You learn different things at each stage, and don't take those for granted. What really helped me is I ended up spending 2 weeks with an experienced minimally invasive mitral surgeon, someone that you may or may not know well, Will Ryan.
Yes.
Okay, so Will became a second, definitely mentor, confidant to me. So I actually got a Texas license.
Okay.
Worked with him for 2 weeks, scrubbed every case he let me do. I'd already been out for 5 years and had some, experience as a surgeon, but working with him, he let me do cases. And then when I had cases lined up, I actually got him privileges where I was at the University of Virginia. And he came and scrubbed with me. And after 3 cases, we were off and running.
Wow.
So that helped a lot.
For the audience watching this, what is minimally invasive surgery and how is it different from anything else?
Yeah, I think that means different things to different people. Obviously, you have to think about what it means to the patient. Patients will come to you and they're terrified. Most of them are terrified of a sternotomy. They don't want their chest cracked. They hear stories, whether from experience or from friends or their doctors, their cardiologists, about what that means. So to them, it's a full experience. I do emphasize what's interesting, if you compare patients who had a sternotomy towards minimally invasive surgery, 6 to 12 months down the road, they probably won't know what the difference is. They've recovered. So I don't want to downplay sternotomy. It's that interim phase between day 2 and 8 weeks where the minimally invasive patients progress a lot faster. So for the frail patient that uses a cane or a walker, there's a benefit. For the young, healthy person that's trying to work and provide for their family, it's very helpful. So there's population. So to me, it's providing something that allows them the most rapid recovery with the least impact on mobility. So obviously sternal sparing, using all the adjuncts we heard about. So using cameras, scopes, lighting, technologies that allow that to happen more favorably. The robot we're hearing so much about.
Yeah. So you started minimally invasive at a time when almost nobody in the world was doing minimally invasive. Like, this is something that's come up quite recently in the past decade, but you were doing it, or you had passion for it long before that. And you said that your first few years were a little tough. How did you overcome that? Because I'm going to enter a period where I'm going to be starting doing it myself. And if I have like 3 or 4 complications in a row, how do you overcome that?
Yeah, no, you have to keep your confidence up. So I'll back up. So I did a few minimally invasive cases, probably 2 to 3 years out. Didn't go so well. Did I think 3 or 4 of them. Took a pause. Got my confidence back with sternotomy. It's like when you're driving fast and you take a curve too fast, you take it easy for a little while. And then decided to think of a different way to train. Not so much the weekend course and watch a surgeon. Now there's simulation and things like that. We didn't have that, of course, but spending the time doing real simulation with a real patient, with a real mentor, that helped a lot. Once I did that and started again, it launched. Yeah. There was not as steep a learning curve. Obviously, you get better and better, but good patient selection is absolutely important. You have to be prepared. I think the best thing I'd say is be prepared for what the complications can be and have a plan in your mind. And ideally have a senior partner or mentor who can guide you through that experience. Yeah,
mentorship is so important in what we do. I mean, a lot of people stand on the shoulders of giants. So what advice do you have for younger surgeons who want to innovate and who lack mentorship? How do you overcome that?
So, I mean, I was in that environment. I had a great mentor, but they weren't minimally invasive surgeons. And I had to find those people outside, people at meetings like this to say, hey, can I come and spend some time? I watch. And fortunately, with one of them, I developed enough relationship that he allowed me to scrub. But I also was in a different phase. I wasn't a trainee anymore. I knew how to fix a valve. I knew how to put people on pump. I'd been out for a few years. So find those people, spend time. I think, again, the model is more expanded now. It's a little bit easier. You mentioned how many more people are doing this now.
Yes.
Minimally invasive robotic compared to, I started in 2012 doing this. So back then, there were several people, but it was much fewer. Here, I mean, every major city has a few people doing this.
Absolutely. And you've evolved your practice so much from the first time you started. So speaking about evolution, let's talk about re-evolution. How important are conferences and summits like these to help people get a push start to start minimally invasive cardiac surgery?
Yeah, I think it's important, that the conferences have also evolved.
Yeah.
And maybe the re-evolution's a really appropriate name, right? So conferences in the past for minimally invasive didn't have a lot of hands-on. Here, this is, in some ways, it's a smaller conference where you can ask the questions that nobody wants to ask when you're at the big meetings, when you're at the big society meetings. Nobody's going to ask about some of these techniques and things like that. And then you get lost, you try to find that speaker, you're not going to find them again, right? So here you have that opportunity. You have hands-on. You can ask the tough questions. You have simulators designed for minimally invasive. So I think it's important adjunct now that didn't exist again years ago. I want to come back to one other thing. You asked about innovation. And one other important experience I had was years ago, I go to many of the society meetings. I listened to Robert Guyton give his STS presidential address.
Yes.
And the take-home message of that was learn a new operation every year.
Wow.
I thought that was pretty insightful. And as I look back now, and even every stage of my career, I can say, I look back now and what I do now is not that similar to what I did when I trained. It's changed. It's evolved. I mean, we still give heparin, we still give protamine, we still use sutures, but the approaches and things like that really have evolved. So think about, for each young surgeon, your career is going to be different in 20, 30 years than it is now, and be willing to adopt and adapt and be willing to listen. We can't be in our holes, bury our heads in the sand and say it's going to be the same way.
Yeah.
That's going to make us dinosaurs.
Absolutely. I was recently a part of the interviews here at Houston Methodist for the CT fellowships. And when I looked at the CVs, they're just unbelievable. Like 20 publications, 30 publications, advanced degrees, PhDs. And if I think about it, when I applied for these interviews like 6-7 years ago, I couldn't have matched. These people were
Feel the same way.
Yeah, absolutely. So how important are these, like, and they're innovators, like they've evolved so much in the way they think. And do you feel like the future of cardiac surgery is bright?
Oh, I think it's fantastic. I mean, you look at the kids, I say, coming through with medical students, residents, they've really thought about the field. They've probably had a lot more exposure than perhaps some of us did in the past. And they've obviously put a lot of effort into understanding state-of-the-art research and participated in it. And I do think, and they're as bright as ever. I mean, obviously you mentioned their CVs, but the number of outstanding applicants, it shudders me. Again, I'm on your shoes. I don't think I would have matched. Feel so lucky now. So I really think, and I actually tell this to our applicants when I see them, the future of our specialty is in very good hands.
So if you could describe the future of cardiac surgery in one line, what would it be and why?
One line is tough. We also, although the focus of this meeting is all on minimally invasive surgery, we have to accept that transcatheter approaches are a part of us.
Yes.
And we can't, as I mentioned, put our heads in the sand.
Indeed.
And say, TAVR's bad or clip is bad.
Yeah.
We do see those cases.
Yes.
The only way we're going to impact change is be a part of that.
Absolutely.
Be a part of it. So in 2010, I started doing MitraClip. Okay. Realizing that there's a future for it. Where that needle is still in question. There's trials going on, and but we as surgeons have to really be involved, because if we're not, it'll go by us. Just like pacemakers, just like PCI,
absolutely,
just like many things. If we say no, that's
not going to work. Yeah.
Yeah, we have to embrace it and do it.
Yeah. Thank you very much for taking time off from your very busy schedule. We really appreciate you having come here. Thank you very much, and hopefully next year we can have you as well.
My pleasure.
Thank you very much.